As you know, I'm Donna Sorkin, and I want to thank everyone for continuing to be involved in this extraordinary network. You may know that this was one of the very first things that we worked on when the Alliance was started, when we got moving in 2012. And the rationale at the time was that the Affordable Care Act was being rolled out, and I knew we needed a way to track what was going on at the state level. So I asked people to join up, and wow, they did. So here we are 13 years later with an amazing network for all of us to contribute to. So thank you very much. And the first important order of business today is to introduce to you our new governmental affairs manager, Monica Yebrin. Monica joined us on October 1. She has an important and diverse background that crosses a lot of areas, and I think she's going to bring some really important insights to our work. So with that, I'm going to turn the floor over to Monica. And Monica, you introduce yourself so people have a sense of who you are and what you've been working on for your professional life.
All right. Thank you so much, Donna. Hi, everyone. I'm Monica Yavram. I can go ahead and share a little bit about myself. I have a background in public health and healthcare policy, as well as clinical practice. I actually started my career in public health before going to dental school to become a general dentist. And I practiced for several years in private practice before moving on to public health dentistry. And then moved on to more administrative roles in public health and policy type roles. I most recently worked with HHS in their policy division, but I've also worked at Cigna Healthcare, working on coverage guidelines, appeals, and grievances, and compliance with different state regulations. I worked at the state level as well as several nonprofit health organizations. In California, I worked at a health center as a dental director, where I was able to combine my public health background and clinical background. I worked at the health center really focusing on patient engagement by strengthening our outreach partnerships, improving follow-up communication and patient education, and helping families really navigate any access barriers that they might have. I think in this setting, I noticed that these types of efforts, sorry, I'm trying to let some people in. These types of efforts help increase participation in preventive and integrated care, and really build stronger connections between our clinic and the surrounding community. So coming back to the East Coast, more locally, back in 2015, I had the opportunity to launch the very first dental clinic for the Arlington Free Clinic, which is located in Arlington, Virginia. And I'm still very much connected to that clinic. On the clinical side, I work to help do things like define the scope of practice that the clinic would have, developing evidence-based clinical policies, and patient education tools, which are really important. I also worked on community outreach, helping to get the word out and connect with various organizations and clinics in the community, as well as helping to secure funding through grants and donors. Today, the clinic has expanded and continues to offer full scope dentistry services to underserved, low income, and uninsured patients. So I am currently working with our team to get up to speed on everything. But in the meantime, please feel free to reach out with any updates or information. I'd love to hear from you. I've already had the opportunity to connect with a few state champions, but I'm really excited to be a part of this incredible group and to support your state level advocacy efforts. And I look forward to working with each of you, and hopefully having the opportunity to meet you in person at CI 2026 in Chicago. So, thank you.
Wonderful. Thanks, Monica. Does anyone have a question or two they want to place to Monica before we move on? Okay, we will move on then. I just wanted to share a tiny bit about the upcoming conference, which I hope you'll attend May 6th through the 9th in Chicago. The program committee is putting together a very special set of events for us, both in terms of the submissions and people we're identifying. We will have a Nobel Prize winner with us, someone who is from Chicago, and he has a hearing loss, and he has some interesting insights he's going to share. Of course, Craig Beckman is our NAPARCO lecturer. And there's one more very important individual that we hope will get as our keynote, but we won't know for sure until February 1. So more on that later. So do plan to come. It's going to be fantastic. And of course, we will meet as a group on Wednesday, as we often do. So with that, let's dive right into our program for tonight. I see Peter Thomas is on, and I have the great pleasure of introducing Peter of the Powers firm. I mentioned earlier one of the first things I did, Peter, was to get the State Champions Network going. And the second important thing that I did 12 years ago was hire the Powers firm. And
Oh,
we've
thank
had
you, Don.
yeah, just an extraordinary collaboration with Peter and his team. And they specialize in disability and healthcare policy. They have an extraordinary network of contacts, both among elected and appointed officials. And we would not be doing our work and being successful without Peter and his group. So, and Peter, we appreciate you, and we appreciate Taryn and everyone else on your group. And so with that, I'm going to turn this over to Peter, and he's going to give us a bit of insight on what's been happening lately in Washington.
Well, thank you so much, Don. A very kind introduction. It's been a great ride. Really enjoyed working with you over the last 12 years. Uh, we have a situation now where the federal government has been closed for over 40 days, 44, I believe, if that's the right count, 43, 44. That's the longest federal shutdown in history, or at least in recent history. Uh, the House of Representatives, right now, as we speak, I was just watching C-SPAN. They're continuing to debate the Senate passed bill that passed Sunday night by getting 60 votes. That's a filibuster-proof majority, and that's what needs to occur for a appropriations bill of this nature to go through and get approved by the Senate. So there were a number of provisions that uh, are in that bill that I want to quickly touch on. The most important, of course, is that the lights would go back on in the federal agencies. Um, the big sticking point that the Democrats had put on the table and had campaigned about for the last 43 days was for the federal government to extend the enhanced tax credits that were passed for Affordable Care Act subsidies. They were passed during the COVID-19 emergency, and they would expire at the end of this year if Congress doesn't act. That's going to mean a very dramatic increase in insurance premiums for millions of Americans. It also is having effect on others who are not necessarily recipients of those premium tax credits, but also rely on the ACA plans, as well as even regular private insurers. I think a lot of people are getting sticker shock with the cost of their health care for next year. And I have, plenty of anecdotal information to suggest that. But without these enhanced subsidies, the cost of health insurance will go up for millions of people who otherwise can't afford it. And the fear, of course, is that millions of people lose coverage. We do expect significant coverage losses if these enhanced premiums are not passed into law and extended. There's proposals to extend them for a year, for 2 years, for 3 years, but at this point, there's no guarantee. It's not included in the Senate bill that the House is debating right now. That's basically calling on that. That means that some Democrats have said that they caved without really achieving much in return. I'm not sure where I stand on that. They clearly defined the issue. A lot more people understand that these premium tax credits are instrumental to them being able to afford healthcare insurance, and that this is going to have a major impact if Congress doesn't do anything to try to correct this. And of course, the president has to sign whatever the Congress does. There's never been any love lost with the Republicans for the Obamacare plans, and there certainly is no love lost for these extra subsidies that were passed during the COVID era. However, there are other provisions in the bill. There is a reinstatement of all federal employees that were fired during the shutdown since October 1, and a moratorium on additional reductions in force until January 30th. So the federal government is not open permanently. It's just open until January 30th, where they have to come back to the table and decide on a new bill. Three departments, the legislative branch, the VA and military construction, and commerce, are being funded full for the full year. That's included in the bill. But the rest of the appropriations bills, there are 10 others, will continue to be on what they call a continuing resolution. So just 2024 funding levels will extend until the end of January 30th. And if they can't agree again, the government might shut down again. But the theory is that they're able to take this time, figure out how to continue passing appropriations bills, and keep the government open. Um, I should say that there is a vote on the ACA subsidies, the premium tax credits that I mentioned, um, and that is going to be sometime in mid-December. The White House just was reportedly today talking over the last several days about ways to bring some proposal to the table to try to prevent millions of people from losing their health care in 2026. But no decisions have been made. The Republicans are unclear as to what their position will be, whether they'll just give in the Senate, whether they'll just give the Democrats a vote, an opportunity for a vote that it needs to pass by 60 votes. So unless they can attract significant Republican support, it's not going to go anywhere and it'll fail. Of course, the promise does not extend to the House. There is no promise that the House vote on premium subsidies in December, and the White House has not committed to sign any kind of a bill. So there's a pretty big uphill battle. Um, there's a couple of other provisions in the bill that I wanted to mention. I talked about the reinstatement of fired federal employees. That means a lot to us because the ACI Alliance has been on Capitol Hill over the last 6 weeks. We spoke with 6 different offices, met with them directly, talked about the importance of IDEA, Individuals with Disabilities Education Act, and the staff that had been fired summarily after the shutdown began. When you have no staff at the federal level for implementing the IDEA law, it's really dependent completely on the states to implement the law itself. And while that's not an end to the program, it certainly does not provide the states with any guidance, with any regulation, with any rules. And they're really it's a free for all. They're really on their own to decide what they're going to do. And so part of the deal was that all of those fired employees since October 1 would be reinstated and no more RIFs through January 30th. That's important news from an IDEA perspective because it means that number one, they listened to us. I'm sure we didn't turn this around alone, but there are a lot of disability organizations were very vocal in opposition to the Trump administration's elimination of the IDEA staff. And I'd like to count this as a partial victory. At least we'll have those staff returning if the House passes the bill tomorrow. If they pass it tonight, the staff will return tomorrow or in the next day or two. And if the House doesn't pass the bill, they're back to square one. And that means that they're going to need to continue to hammer out some kind of a compromise to pass the a budget that will reinstate the government and to reopen. This is a very close vote in the House. There are only two Republican votes that exceed the number of Democrat votes. There was a Democratic congresswoman who was sworn in today, replaced her father in New Mexico, who passed away earlier this year. She ran, she won her election. She hadn't been sworn in for 40 days. She could have been sworn in a long time ago, but they hadn't convened. The House had not convened. And so now they convened and they swore her in, which means that the 3 vote margin in the House goes down to a 2 vote margin. And there's a number of people on the Republican side who easily could balk and walk away from this vote. So we don't know what's going to happen later tonight. It's kind of high drama right now as we speak as to what's going to happen with this bill. Again, if it passes, the federal government reopens at least temporarily, and they'll continue negotiating throughout December and January, and hopefully the government will remain open for the rest of this fiscal year, which ends on September 30th of 2026. So that's the appropriations situation. There's all kinds of problems with the rest of the funding levels for Department of Health and Human Services programs. The Senate says that they're going to start looking at the labor HHS appropriations bill soon in the next couple of days and into next week. Uh, Luckily, the House and Senate Appropriations Committees rejected some of the deepest cuts that the Trump administration put forward, a $20 billion cut to NIH funding, for instance, a $19 million cut to funding for the National Institute on Disability and Rehabilitation Research. We don't know where that one's going to come out, but we do know that the Congress rejected, both sides of Congress, the House and Senate, rejected that $20 billion NIH cut and ultimately is going to likely pass a budget that level funds the NIH at $47.5 billion. That's a huge amount of dollars. It's the largest biomedical research enterprise in the world. And to incur a $20 billion cut in 1 year would have been absolutely devastating. So they'll go through those bills and they'll try to agree on those bills so that they can conference the House and Senate bills together and arrive at a final bill. So plenty of work to be done by the funders, by the appropriators. But it has all kinds of implications on healthcare, disability, and in fact, cochlear implant access. Let me quickly mention Medicaid, and then I'll stop talking and take any questions that people have. Medicaid obviously sustained very significant cuts in the what I call the OB3, the One Big Beautiful Bill Act, which I find difficult to say because there's little that's beautiful about it, especially when it comes to Medicaid. They cut almost $1 trillion from the Medicaid program over the next 10 years. And that's going to mean less access to care, less people insured by the Medicaid program. And remember that Medicaid is the safety net program. That's the payer of last resort. When you show up in a hospital and you don't have insurance coverage, Medicaid is the payer that covers that care. Or it's bad debt, and the hospital has to eat that care and eat the cost of it. That's going to start happening a lot more under these changes that occur, some of which don't go into effect for 2 or 3 years. So you'll see the Medicaid program ramp up at various stages starting on January 1, but some of the worst cuts are in 2027 and 2028. And you'll see states grappling with how do they balance their budgets, how do they fund Medicaid at an appropriate level and still not dramatically increase the amount of state funding that has to be devoted to the program. And the way they do that typically is to limit access to the program in the first place. They cut the rolls, they cut enrollment, they cut eligibility for the program altogether, rather than going in and surgically cutting certain benefits. Now, they might find that the gulf in funding is so great that they actually have to go in and cut some benefits. I know that in California, just a couple of months ago, there was a proposal to cut a number of different types of benefits, including access to um, anti-obesity medications. In Texas, just a couple of weeks ago, there was an effort to cut a whole host of benefits with respect to wheelchair technology and seating systems. So, these states are not immune from cutting individual benefits, but by and large, the way that they reduce spending in Medicaid in order to comply with the federal law is by cutting the rolls. So, imposing work requirements that really serve to cull out people that don't file appropriate paperwork in a timely manner. Um, Other kinds of provider tax schemes that the states have come up with that for years have been able to draw down additional federal funds. They're placing moratoriums on that. There's a lot of minutia. There's 5% cuts here or there on the amount of the federal dollars that flow to the states. But the end product is a dramatic reduction in Medicaid funding over a 10-year period. And while I'd love to say that certain benefits are going to be held harmless, I do expect some real pain over the next several years, unless there's an election and this gets turned around. There might be a groundswell that says we never voted for these big huge Medicaid cuts and we don't want them, and they may wind up Congress may come back, and if there's a pretty significant change in the populace and in the vote tally, you might have a situation where some of these Medicaid cuts never actually go into effect. But at this point, I would recommend preparing for the worst. And right now, it looks pretty dire. I hate to be the bearer of bad news, but this was passed back in July. And the reason you probably haven't heard all that much about it is because, again, many of these changes go into effect over a 3-year period. Donna, I'll stop there, and I'm more than happy to answer any questions that people have.
Anybody want to put a question to Peter about what he's just presented or anything that's related? Peter, I have a question for you. The funding for Eddie, the 18.8 million, it's a small number that we advocated for and were able to get put back into the budgets that came from the House and the Senate. Is that likely to stick in the vote that's going on right now?
So that's included in the labor HHS appropriations bill that has not yet been, that's not included in this particular bill. What would happen under this particular bill is that the EDI program would be funded at the same level it was funded in 2024. Um, and because last year we had a continuing resolution, it actually would be, well, I'm off 1 year because I need to talk about fiscal years. We're right now debating fiscal year 2026. So assuming the lights go back on tonight, the Congress passes the bill, uh, that EDI program would be funded at the fiscal year 2025 funding level, but that's actually the 2024 funding level because there was a continuing resolution last year as well throughout the entire year. So it's the same level of funding. So it's not getting increases. They're not getting any recognition of inflation or anything like that, but at least they're getting the budget that they originally had. That will be reinstated temporarily until the end of January, and the Congress will hash out what the final number is for fiscal year 2026, which again ends on September 30th. And I do expect it to be consistent with the previous amount of funding that it's received. So even though the Trump administration dramatically cut that program, in fact, I think they zeroed it out, right? They ultimately would restore that funding to where it's been all along. That was a big effort of ours, and a lot of other people fought that too. Of course, many people in Congress support that program and don't want to see that program go away. So it wasn't a fringe program. That's like a bedrock success story in healthcare. Um, so I don't have many concerns about that at this point, but we still have to be vigilant. We have to watch it closely, and I'm pretty hopeful that we'll be able to get that funding restored.
That's good news. Anybody have any other questions for Peter?
I see
Um,
Linda has a question.
Hi, Peter. Yes, and I am the Vermont EDI program director in Vermont. So, question for you: in the original bill, the CDC funding was kept, but the HRSA funding was added in more recently. So, EDI is funded by both CDC and HRSA. So, I just want to question you about: does that mean that both those funding mechanisms will be in place in this
That's a
coming?
that's a great question, and I don't want to commit definitively without being right and not knowing that I'm right. I was really primarily talking about the HRSA funding, so I would want to look a little more closely at the CDC funding. But I can tell you that there's strong support in the Congress for the EDI program, and I don't really
Great.
expect that the House and Senate are going to find savings in that kind of successful public health viewed as a public health program. Uh, sure, CDC got a huge cut by the president's budget. The budget for FY for the existing budget was 9.2 billion. The president offered something like 4.8. I mean, it was a dramatic reduction, but that was largely, and many of the other programs that received those kinds of unrealistic cuts, those were largely reinstated by both the House and the Senate, more so by the Senate than the House. I think the Senate was more generous than the House was, but they still have to agree on a final number. And they may compromise at some slightly lower number, but there's no way they're going to just eviscerate those programs. They're too important. They're too successful.
Thank you, Peter.
I'm sorry, I have a quick question. A little bit on the flip side. I'm seeing more and more providers not accept either Medicaid or Medicare individuals, presuming that they stay on those rolls. Are you seeing that? And mainly because of the reduction in the reimbursement that the providers are receiving. Do you have any information on that?
Um, well, to walk away from Medicare and Medicaid is a big decision by a provider. That really means that they're private insurance and paying out of pocket. Uh, it's not an easy thing to do either. You can't accept the ones, you can't accept it sometimes and not other times. You're either a provider or you're not. So that's a big decision. I suppose it depends in part upon where that provider is located and what the socioeconomic demographics of that particular region are, whether they can tolerate living on private insurance and VA claims or out-of-pocket payments. But most providers can't. Most providers need that revenue from Medicare and Medicaid to make ends meet. Um, I have not personally heard of CI providers, I presume you're talking about, or really any other provider kind of walking away from those programs. But the frustration level with those programs is clearly growing amongst physicians, amongst therapists whose fee schedules have not been raised significantly in several years, and they're constantly fighting not to get a cut in their fees. Um, Clearly, the frustration level is peaking, but I just haven't heard a whole lot about people just walking away from the programs altogether. That's pretty alarming what you're saying.
I agree with what Peter said. I think over the years, sometimes what I have seen is that hospitals informally have encouraged providers to slow it down for CI if the reimbursement is really horrific. I have not heard that ever for Medicare. Medicare reimbursement rates for CI are generally pretty good. But in some states, the Medicaid rates are very low. When we've done some collection of data on that, there it is possible. I don't know in this environment whether it's as possible. We have it at different times gotten Medicaid rates up by meeting with Medicaid offices and demonstrating to them the importance of the program for CI. So if you have that issue in your state, let's not do it tonight. You can contact me and we can talk a bit how to do that. I have worked in Georgia, Faith, back in the day on reimbursement in your state. I've worked in Texas. I've worked in a number of different states to get those rates up, and it is possible to do it. But I agree with Peter. I haven't seen providers walking away from Medicare and Medicaid, particularly large hospitals and the ones that conduct CI.
Okay.
I
I
Right.
saw some publications where the rates of reimbursement to providers are going to be reduced and maybe even significantly reduced, and whether that would then result in providers stepping away from accepting individuals with Medicaid and Medicare.
So that may very well happen, Faith, for Medicaid in a particular state.
Hmm.
Um, State regulators have three ways that they can reduce their Medicaid expenses. They can cut benefits, individual benefits. We're no longer going to cover CI. They could reduce the rate of reimbursement, or they could limit eligibility to the program altogether. And most states believe that and I think the empirical data is such that it's you achieve the maximum amount of savings that you're targeting by simply limiting the scope of the program. And so limiting eligibility to the program is what typically occurs. But the states can do any one of those three things, and there may be states that choose to reduce reimbursement rates even further than Medicaid rates already are. I mean, Medicaid rates are typically pretty low as it stands, as you all well know. Medicaid rates are not going to change because of the OB3 or the shutdown. Medicaid rates are kind of set by statute, and there is a fee schedule depending on the different types of settings in which you're being reimbursed. So it's really more of a Medicaid issue, I think.
Okay, thank you very much.
Just a quick question, Erica Walsh, University of Alabama. So I'm a state champion for a state that does not cover, for the most part, cochlear implantation at all in adults under Medicaid, one of the few kind of holdout states. Is there any hope for any of us politically who are in states who don't have Medicaid coverage for adults? Is there even a way to approach this topic right now? And this may be something that's better in another forum, but I wonder for those of us who are in states who already have pretty big coverage restrictions, what that landscape might look like.
Well,
That's next on
it's
the agenda, actually. So I would just wait. I mean, I have two people here who from states that have done that.
happy to wait. Let me just say I have breaking news. The House has passed that bill 222 to 209. And so the federal government will reopen, and everything I talked about in the first 10 minutes of my little talk here is relevant. So I suppose that's good news to get the country back open again, the federal government back open again. But a lot of these problems will need to be worked out over the next couple of months.
Um,
It's great.
I just wanted to say something as far as what I'm familiar with as far as providers walking away from is contracts with Medicare Advantage plans. And I think a number of providers starting January 1 are canceling a number of contracts with Medicare Advantage plans is what I have observed, but not traditional Medicare. I just wondered if perhaps that was what it had, the Medicare question had to do with.
That makes a lot of sense. I would want to hear from Faith as to whether that's really what the issue is with Medicare. More than 50% of the Medicare population now is on Part C, Medicare Advantage, and those are all health plans that have contracts with the Medicare program to provide the Medicare benefit. But of course, they have the ability to negotiate uh, reimbursement rates with providers, and they have the ability to impose prior authorization or other utilization mechanisms to limit access to care. I would say limit access to care. They would say to make sure that they're covering appropriate benefits and that the patient really needs it. But ultimately, we all know that Medicare Advantage plans often use prior authorization to enhance their profits. And in fact, the Office of Inspector General has two reports, one in 2018, one 2022, that have demonstrated that very thing.
Um,
Kaylin?
Hi. I have a question. Some of us, it looks like a couple of us are going with ASHA next week to Capitol Hill to meet with our some of our state representatives. A lot of what you discussed, Peter, was what they advised us to talk to our reps about. I'm feeling a little bit overwhelmed by everything that we have to present to them because I just have a lot of I'm very passionate about most of the issues that are on the table right now. But do you have any advice on what we should talk about in these policies, or what best to say in these meetings? I know that's a broad question, but
It is. I'll give it my best shot. The substance of what ASHA brings to the actual Hill to try to accomplish may change between now and your fly-in, because frankly, there's a lot of change happening right now, right? They just passed this major bill. There's some provisions in there that they wanted. For instance, telehealth is retroactively authorized back to October 1 and forward to January 30th. All of the same rules that always applied over the last several years to telehealth under Medicare are reinstated. That's huge. I'm sure that probably was one of their agenda items. Well, that's now extended to January 30th, but it's not extended through the rest of the fiscal year, and it's not permanent. So they very well may keep that issue, but kind of tweak the messaging. But overall, I think the important thing to convey is your own expertise with cochlear implants and your patient experiences, obviously without mentioning any names or disclosing any uh, PHI, but to express to leave in their minds the image of what it means the first time a child hears with a cochlear implant, and how fulfilling it is for you, but also that family, and the experience, the gravity of the value of cochlear implantation. If you can get that across, that's your job. The job of convincing people to adopt a certain policy, that's ASHA's lobbyist's job, and it goes on all throughout the year. But when they bring you guys in, what they're looking for is you to make an impression. They're your constituents, or you are their constituents, and they're looking for you to land some compelling images that they'll remember and they'll understand. So just keep that in mind. I would focus less on the substance of the specifics things that they're asking you to do. If they ask you to have 6 different asks on telehealth, what you need to say on telehealth is, this is critical for us. Let me tell you about how telehealth works in our field. Let me tell you the experiences that my patients have had with telehealth. And that's what they want from you.
thank you so much.
I hope that helps.
That does. Thank you.
One more question for Peter, if you have it. And otherwise, we're going to move on to some other agenda items that we have.
Well, I do want to answer that question about, was it Alabama that we passed?
Yeah. I mean, that's actually on the agenda in terms of some of the state champion work highlights. So I'm going to skip down to that item. because we have two states actually that have recently been successful in passing state legislation to cover adults under Medicaid. And one of the people that led that effort is actually with us. It's Kate Sinks, and she can tell you about her. I think it was a 3-year effort in Missouri. She put together an extraordinary coalition of clinicians from around the state. And just a few months ago, they were successful in getting legislation to cover adults under Medicaid. Kate, you want to give just a few minutes on what you did, because it is possible to change Medicaid coverage.
Yeah, sure, Donna. Thanks so much. So yes, to the person in Alabama, it is possible to do, and Missouri is living proof of that. We never went into this honestly with expectations that we would be successful, but it was always a dream, and we worked very, very hard, and the dream came true. So we did get it was about 2.5, almost 3 years of work to get this through all the way through both chambers of the Missouri General Assembly. But we got it successfully done this year, actually through a combined bill is how we got it very last day of session on the House side. So it was a Senate bill that made it through, and it was signed into law by Governor Kehoe in July, went into effect end of August, and I am actively filling out Medicaid prior authorization forms every day. So, but yeah, it's if anybody wants more information, just kind of like on how we did this, like what steps we took and kind of what that process was, more than happy to talk offline.
Yeah, I would love to know kind of the maybe like first step. I'm in Utah. I'm at the University of Utah. And there's a couple other people from Utah on this call. And one of the pediatric audiologists and I, Katie Tonkovich, have talked about it. I'm an adult audiologist, and there's a whole generation of kiddos that were implanted that are about to be aged out of the pediatric world, and we are very stressed about it. So I would love to connect to see kind of what some of those first steps are. Utah has its own kind of situation right now where we're trying to not lose our licensure. But once we hopefully take care of that, then this is my next plan.
Yeah,
Certainly happy to
connect offline, because we got some other things, and
Yeah,
they had
sure.
had a very sophisticated process that they carried out in Missouri.
Great.
Yeah, so we'll connect you up. The other place where they did this was another very red state, Arizona. And Sean Stevens, who I don't think is on with us tonight, is a surgeon there, and he took him about 3 years. They got a volunteer lobbyist from a hotshot law firm in Phoenix to provide service support to him. And he just kept going back. He would get turned down 1 year, and he went back the next year, and he was finally successful this year in getting adult coverage. So I could link you up also with Sean. He used a little bit different approach than they used in Missouri, but they were successful. And we have some notes also about first things to do. They also did this in Washington State. We worked with, it was a different process that we used in Washington. We didn't go the legislative route. We went at the administrative route and got it addressed in Washington State as well. So it is something you can do, and it's going to be modified depending upon your state and the specific situation that you have. Okay, we'll get something out to everybody about who to talk to and resources on it.
One quick question about it, Donna. Do you feel like that those additions of adults could be one of the things on the chopping block if the Medicaid cuts really go through? Are you worried about that?
Of course. Yeah,
Okay.
of course. Who knows what's going to happen, whether they'll keep keep that in effect. I mean, I think the other thing we don't have time to talk about tonight, but something that we are going to work with Powers about is how you as clinicians, what steps you can take to try to retain access for patients through Medicaid, and some of the things you can tell your patients to do in terms of remaining enrolled in the program, and other things that you can try to do if they try to reduce the reimbursement even more. So that's a project that I promised my board that we would work on, and Peter will talk some more about it at another time, because I think you can give some guidance to patients and others about how to keep the Medicaid access flowing.
Yeah, it's a great project to take on, especially now, and try to sustain it over the next couple of years as these cuts continue to loom. Um, and maybe we do something like a toolkit. We don't need to talk about it now. We'll talk offline, but something that can prepare people, a set of materials that they can use, and kind of instructions or suggestions as to how to go about bringing the most pressure to bear to keep the benefits that the state has, and in states that don't have it, to expand it.
Yeah, and for sure, we'll continue our efforts at the national level.
Yes.
Yeah. So with that, I'm going to circle back up to one of the agenda items that we skipped, and that is some of the other public policy efforts that we've been undertaking over the past 6 to 8 months. And the first one, of course, was Eddie. I'm not going to spend much time on that, other than to thank everybody who was involved in those meetings. That was organized by another amazing member of the Powers team, Taryn, who has great contacts on the Hill and set up those meetings for us with people in the Senate and the House, both sides of the aisle. And we had incredible work done by some of our state champs, Yvette Cias, who's actually a psychologist from University of Miami, who's done a lot of research work on the long-term benefits of early CI in children, as well as the cost effectiveness. And Yvette did 6 meetings on mostly on the Senate side, particularly with Florida legislators, and she was awesome in terms of making the case for the benefits of this. She used her work that you can access. We actually funded it. It's been published and in JAMA and in the Larnoscope on additional work that they looked at beyond what John Naparco had done over his 10 years of NIH funding. If you all haven't read that, it's accessible on the website. I believe it's under the research tab, but I can remind people where it is. But that's basically what she used in her discussions with legislators. We met with staff from Kentucky, Senator Rand Paul's staff. That was handled by a Kentucky physician, Matt Bush. We met with the Senate Finance Committee. We met with Senator Thune's office, as well as the minority leader. And the House side, we met for the first time Congressman Moran from Texas, who has a child with a cochlear implant, and they were very interested in Eddie and in Medicaid and the importance of Medicaid for children, where 50% of our kids are funded under Medicaid. So we had some very good discussions and relationships that we built with those offices from that contact. And of course, I'm going to brag and say we had an impact in getting the money restored, because that's what we do. And we certainly had as many meetings on Eddie as anybody in the field. So I think that's a fair accomplishment for us to be talking about. And then the other thing I just wanted to give you a brief update on, because I know you're interested, and that's the NCD for single-sided deafness under Medicare, and that is ongoing. We had a number of meetings with with CMS about that. Peter's firm was involved in setting those up and supporting our efforts. We had initiated that NCD process, and we were advised by the CMS staff that they wanted us to pull it back and come back in with more published research before we actually asked for the formal start on the NCD. And so that's what we did. The research efforts being led by Dr. Murakasati in New York. And there have been, I guess there's a recent study that was published on VA candidates who received SSDCI. There's a study that's coming out soon on work that was done in Seattle. And then what Dr. Casati is doing is collecting data from 12 different sites. They're all collecting the same outcomes data on older adults that have received CI and funded in different ways. So that will be the basis of a publication. Once that's out, we will go back to CMS and have a discussion about going forward with an NCD. When that happens, we will be calling on all of you to support that effort. When there is an NCD process going on, as there was a couple of years ago when we expanded bilateral, there is a process for public comment, and that public comment process is hugely important. So we will keep you in the loop and support your efforts to come in and put comments in at the appropriate times. So that's going on. I'm going to hand the floor over to Monica to give you some background on what we've been doing on IDEA. And she can share on that.
Thank you, Donna. So just wanted to talk a little bit about some of the advocacy that we've been working on to retain IDEA. I know that Peter talked a little bit about this earlier. Donna, myself, and Taryn have been meeting with Republican legislators. Taryn has been great in setting up some of these meetings, and we've met with about 5 offices, and I'll kind of list them. We've met with Representative Bost in Illinois, Representative Moran in Texas, Representative Bacon in Nebraska, and Representative Stover in Minnesota, and lastly, Representative Thompson from Pennsylvania. So we've met to discuss the importance of retaining this program. As you may know, and I think as Peter mentioned earlier, there are a lot of staffing cuts and changes, potential restructuring that's happening at the Department of Education. And this has raised some concern because the Department of Education oversees IDEA. So I just wanted to kind of share some of the discussion points and rationales that we went over in our meetings. We really talked about how IDEA plays a vital role in ensuring continued support for children who are deaf or hard of hearing, as well as a foundational to early identification and intervention that directly influences a child's hearing, their language development, as well as their long-term outcomes. We also talked about IDEA Part C, which provides families with essential services and support early in the first years of life, so from birth to age 3. And then Part B provides continued support in school settings. The other thing we did was we shifted to a more administrative focus and talked about the importance of the national staff and offices of special education, such as OSERS and OSEP, and how they've played a really key role in ensuring that the law is implemented as it's intended, meaning families have true informed choice and options during these early stages. And then the staff also has a very deep understanding of hearing loss and disabilities. So they're able to provide invaluable, they're invaluable in helping prevent any unintended consequences that can happen from inconsistent and variable implementation of this law. So just kind of in summary, We really wanted to have clear messaging during these meetings about the importance of maintaining a robust IDEA program and the importance of national oversight. It's essential to ensuring consistency, decreasing variability of how the program is implemented at the state level, as well as supporting family choice and ensuring equitable opportunities for children who we serve. We've had some pretty positive response and feedback from the offices. I think the representatives have confirmed that they will continue to champion and support this program, which is wonderful, as well as funding for IDEA and continuing to advocate and invest in children with disabilities. So that's great. We talked about them joining a letter in support of IDEA. So looking to hopefully have a more broader sign on to the letters. And then just in closing, as we continue to get the lay of the land, I think we will plan to send a You Join action alert to emphasize the importance of IDEA. So we would like to have as much participation as well as many comments as possible. So please keep an eye out for any upcoming You Join alerts. Donna, did you want to add anything to that?
I don't think so. I think you did a fantastic job, Monica, of characterizing the work that we've done on that. I want to just ask Linda Hazard if she has anything to add beyond what we've talked about in terms of what's happening at the state level relative to Eddie and both on the HRSA side and the CDC side. You had noted that some states were starting to decline their their funds and what the impact of that might be.
Thank you, Donna. So I would just add, so HRSA funding, which is 235,000 a year, is for all 59 states and territories. And the CDC funding, which is currently for 38 states and 1 territory at about $169,000 a year. So what's happened recently is we've had 1 state turn down the HRSA funding and decided to also turn down their CDC funding this year, and that state is Oklahoma. And they are looking at funding their EDDI program through their own state system. In March of 2025, EDDI program submitted a CDC new cooperative agreement, but because all of the CDC staff, EDDI staff was let go on April 1st, the CDC was not able to review those cooperative agreement applications. So they made a decision to extend for another year the current states that have awards. Unfortunately, because of the very short time frame, there were a few states who could not get the applications through their approval process and had to turn down the CDC extended year funding. And that was probably 2 or 3 states in total. The rest of us did extend for this year. We have no idea, obviously, about what's going to happen with the applications that we submitted last year or whether we will be submitting new applications this year. But in general, I would say EDDI programs are proceeding with all of our work, which is really important. But it is concerning that some, like Oklahoma has declined that funding. We are all of the states are looking at sustainability for EDDI programs beyond federal funding in case it does go away.
Thank you, Linda.
You're welcome, Donna.
Does anyone have any other questions or comments, areas that they think we should be focusing on? A number of things have come up, and we've recorded this, so we will definitely follow up on everything you said. Andy?
Yes, thanks, Donna. I'm Andy Hill. I'm one of the state champions from Alabama alongside Dr. Erica Walsh and Wilder Roberts. Monica, I was just curious, as to which letter you're talking about signing on. That was one of my specific questions based on other advocacy organizations I'm a member of and participate with.
I believe it was the letter from Representative Fitzpatrick.
Okay. Okay, thank you.
Yes, of course, you're welcome.
And when we spoke to various offices about IDEA and that letter, everyone that we spoke to, and it was that we were only talking to Republicans recently. Everyone said they were interested in learning more and potentially signing on. So I think there is, as Peter said earlier, a lot of recognition of the benefit of the EDI program and IDEA.
I wonder if it could be utilized as somewhat of an opportunity for representatives and other policymakers to better understand some of the specifics of IDEA that protect children who are deaf and hard of hearing. I appreciate what Monica said, that there are some people perhaps within OSEP and OSERS who are aware, but my personal experience is that there's still a lot of awareness that's lacking in terms of some of the special factors that are in IDEA and how those should be implemented in IFSP and IEP documentation. So, but happy to talk about that more offline if that could be
That's
helpful.
a very legitimate point, Andy. I think we went specifically to offices where we knew the members were familiar with and very supportive of IDEA. But you bring up a really good point, which is perhaps we should be using them to spread the word to the rest of Congress of the importance of this. So
Right.
that's a great comment, and we'll see how we might be able to bridge what we have learned from the offices that we met with.
Well, great. I appreciate all of the efforts. It sounds like you all have had quite a number of meetings. So thank you.
Yeah, Peter.
I'm afraid I have to drop off. Is there anything else that you'd like me to address, or are we good?
I don't. You were amazing tonight, as always, and we appreciate your time at such an incredibly busy evening as tonight was. So
Yeah, we're gonna have
thank
to
you.
write this stuff up now, so I'm going to that next. But thank you very much, everyone. Have a great evening and a
Thanks,
great
Peter.
week. Talk
Thank
to you
you.
soon.
Thank you.
Bye-bye.
Thank you, Peter.
Does anyone have any other comments or questions? We're 5 minutes over and we do try to stay kind of on track, but it's such an incredible evening of action that we can go a little over if anybody has any comments or questions. There were things that came out that we will follow up on. We will link you up with our champs who have carried out adult change in Medicaid. So we'll hopefully, Kate, you're willing to talk. I know you probably will, and we'll also talk to Dr. Stevens in Arizona, and write to Monica if you want to talk, if you want to have that kind of linkage. And we'll be happy to do that. Kate, I know you wrote in about support for the wacky bill that's underway for cardiology, and we're following up with that.
The bill should be, just so you know, the bill will be presented to the legislature on November 19th, which is next Wednesday. So,
All right, we're on it.
Thank
okay.
you.
Thanks for bringing it to our attention. If we will be at ASHA, we have a booth, and Monica and I will be buzzing around, going to sessions. If anybody wants to meet up for lunch, shoot us a note, and we'd be delighted to see you in person while we're there for the main conference. We're not going to the Hill as part of the ASHA events, but we will be at the conference for sure. And please, please plan to come to Chicago. It's going to be an amazing meeting. You may have heard the news that I'm stepping down from being executive director of this extraordinary organization. I will be in place through May. And I will be in Chicago. So come and celebrate everything while we're there, May 6th to the 9th. Okay, if there's nothing else, we'll say goodnight. Thank you for coming on, and thank you for everything you do every day.
Thank you. Good night.
Night.